Kerry.
Good morning, my lady. My first witness today is Miss Joanna Killian.
I swear by Almighty God
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Good morning. Thank you for coming along
you.
to help us.
Thank you.
Ms Killian, your full name, please.
My full name is Joanna Elizabeth Killian.
You, on the 18th of March 2024, became the Chief Executive of the Local Government Association, or LGA for short, is that correct?
I did.
And prior to that, during the pandemic, I think you were the Chief Executive of Surrey County Council.
I was.
All right. I'm going to ask you, please, about the LGA's role, but if it would help you to give your evidence, to give us some examples of actually what happened on the ground in Surrey, please feel free to do so if you think that would help.
Thank you.
I know that you set out in your statement that in preparing the statement, you have spoken to officers who were in the LGA at the time of the pandemic. And may I thank you for your assistance in preparing and collating the survey responses in November 2024 about the pandemic response. You set out in your statement a description of the Local Government Association, whose membership, I think, comprises 331 of the 333 principal councils in England and the 22 Welsh councils.
Yes.
Right. And can you just help us at the outset, please? Can you give us an overview of the role of the LGA and, in particular, the role of the LGA in the pandemic response?
Yeah. I mean, before I do that, can I just say, as Chief Executive of Surrey County Council, I was in that role co-chair of Surrey's Local Resilience Forum and chaired a number of the Gold Command meetings that conducted the pandemic. I also was chair of a homeless charity, so saw the pandemic through a number of different lenses. In relation to the LGA's role, we're a voluntary membership body, but in that role, we liaise significantly between local government and central government. We lobby on behalf of our councils to make sure that policy decisions can land well in places and make a difference to people that live in our places and communities. So we interpret guidance, make them fit for purpose. We lobby for money, but we also do an awful lot of work to support councils and their partners improve the quality of services to people living in their communities.
And help us, does the LGA have a direct line into the Department of Health and Social Care? How did it work during the pandemic?
So the LGA has and had at that time very strong relationships into a number of departments that were running the pandemic, including the Department of Health.
Presumably also MHCLG, as was.
Absolutely.
All right. Ms Killian, can you take it from us that over the last 4 weeks or so, her ladyship's under no illusions about the underfunding and the fragility of the adult social care sector. But I would just like to ask through you, please, to have a look at what the LGA members said in relation to pre-pandemic capacity. And could we have a look at one extract from the survey, please? INQ 400-522_21. Because I think one of the questions that you posed of the membership was how they would judge the following elements of the adult social care sector in the year leading up to the COVID-19 pandemic. And if we look down, firstly, at preparedness, a relatively mixed response there, with 22% of the English single tier. Can I just ask you to explain what the single tier is, please?
Yes, so upper tier councils or single tier councils are responsible for the delivery of care services, including adult social care. District councils provide support into that endeavour.
Okay. So we can see that 22% of the single tier and counties thought that preparedness was fairly good, 53% not very good, 20% not good at all. And in Wales, 19% of the authorities thought fairly good, 57% not very good, and 29% not good at all. I'm going to come back to pre-pandemic planning in a moment, but capacity, actually in England, 65% felt fairly good, and similar scores for 67% in Wales. The ability of the care sector to increase capacity, was that increase the workforce numbers?
Workforce numbers and potentially capacity within the provider sector itself.
Thank you. Fairly good, 43% in England, 38% in Wales. Not very good, 47% and 43% respectively in England and Wales. And then resilience was in fact by the respondents, 70% in England thought it was fairly good resilience, 52% in Wales. And that might not necessarily accord with some of the evidence we've heard about the resilience of the sector. Can you help at all with your perspective on why some of the respondees might have actually said in England there was fairly good resilience when we've heard perhaps that there wasn't?
So I think one of the extraordinary and sort of distinguishing features of the care sector in England is the goodwill, the sort of the passion amongst the workforce, amongst providers. And I think that really shone through in the pandemic. So over time, the sector has coped with reducing amounts of money. The sector's just about coped with increasing demand and changing demographics. And that has required them to be innovative, creative in sort of building solutions that could make people's lives happy. So there's something inbuilt about the culture there. But, you know, the pandemic definitely tested that resilience for sure.
And perhaps slightly lower figures though in Wales, with only 52% of the authorities there thinking that resilience was fairly good, and indeed 38% saying not very good. Can you help with why perhaps there's slightly different figures for Wales than there are in England?
I mean, I don't feel sort of confident about talking about figures in Wales, but the legislation is different. Some of the models of care are very different between the two nations.
Right. And thank you. Before we look at some of the pre-pandemic planning, just some overarching observations from you, if I may. In your statement, you say that the notion of the protective ring was known to be untrue and caused distress for families and for those working in adult social care. Can you help Ms. Killian with why that's the view of the LGA?
So it was clear to us from the start of the pandemic that priority was placed in supporting the NHS. I think the Department of Health understood or believed that the NHS delivering sufficient capacity in hospitals, enabling discharge was necessary to be able to support people that might become unwell. Our experience from the start of the pandemic was that sort of continuing focus on the NHS shifted, I think, esteem away from social care. It led to poor decision-making about the allocation of resources, whether that was for PPE to begin with or vaccinations. It was clear to us that decisions about discharge actually put some care homes at threat of harm. So despite great work that our sector did with care home providers, it wasn't the case universally that care homes were great, safe places for people to be. I think it was also a terrible misunderstanding of social care in England that so much focus was around care homes. A much higher proportion of people live happily and independently in their own homes who need care and support, and their needs were not addressed early enough in the pandemic. So we saw holes in provision, and we cannot agree that there was a ring of protection around care homes or sometimes individuals' homes either.
Do you think it was that the department's plural didn't understand the adult social care sector, or just got the focus wrong in view of what they thought might be a need to effectively free up as many hospital beds as they did? Do you have a sense of which, if either or both of those statements might be true?
I think it's both, and probably more actually. I mean, in the early days of the pandemic, it was clear that there were insufficient numbers of very senior people within the department who understood what adult social care was, how it was delivered, and the importance actually of thinking not just about older people, but actually groups of other people that needed care and support in the community. So I think in the early days, insufficient capability or leadership to be able to sort of understand some good policy makers, but again, a gap between how policy might work in theory, but actually how it would land. So I think absolutely a misunderstanding there.
And what led to that gap, Ms. Killian?
I think there had been historically, no senior director general at the point the pandemic started, a small number of people, and we accept that the number of officials working on this grew significantly. But this goes to the heart, I think, of how we find ourselves today, that social care was just not a sort of priority in the department against the priorities that there were for the NHS. And again, as the LGA, we accepted and understood the evidence that was in play at the time that recognised that there would be benefit in releasing capacities in hospital, because actually some of the people that might be affected were older people. So there was a sort of a logic as the science developed. But our sense always was that to make capacity available in hospitals, there had to be a safe way of ensuring that people left hospital, preferably to go to their own home.
Was there any sense that the gap between the policy and the actual sector on the front line was as a result of a lack of engagement with the sector?
So I will say again, I think there was a lack of sort of experience within the department, and in the early days there weren't the sort of mechanisms, the robust mechanisms to liaise with local government associations, providers, service users. And although that improved sort of notably in June 2020 when David Pearson was appointed to lead the social care task force, lots of things were done on an ad hoc basis. The LGA was often asked, and we were happy to do so, often asked to comment on guidance, but the guidance often came late, short notice, and sometimes it felt that guidance had just been adapted from an NHS workbook into a social care workbook. Older people living in residential care homes do not live in wards. They live different lives in residential homes, in care homes, and guidance was frequently changing. So as the LGA, we absolutely offered ourselves and others into a space where we could support the department, and things did improve, but at the beginning it wasn't the most satisfactory set of arrangements for any party, and nor for the civil servants who really did want to make a difference.
No, we might come back to that in a moment. Can I just start there with some pre-pandemic planning? Yeah. And I'd like your help perhaps on clarifying different levels of plans that are in place. We have heard from a number of witnesses about the pre-pandemic flu plans. Yeah. We've also heard witnesses talk about business continuity plans and indeed contingency plans. And I wonder if you could help clarify what the plans are meant to be in place and who was responsible for those plans, please. So could you start with the pre-pandemic flu plans? Was every local authority obliged to have a pre-pandemic flu plan?
So, as you say, it's important to sort of think about the hierarchies here. Government nationally should sort of periodically define the threats to the nation. And as local authorities, we pay attention to those threats. The local resilience forum that are formed under the Civil Contingencies Act are accountable in places for making sure that a county, a group of counties, whatever the footprint of the LRF, are ready to be able to respond to these national emergencies, and absolutely the flu pandemic was part of that. As an individual responder council, absolutely it's for the council to be able to say that they are sort of ready to respond to a national emergency, in that case a flu pandemic. it's the responsibility of a director of public health within a local authority to make sure that planning for infectious diseases under the 2012 Act are in place. So there's a variety of hierarchies, but absolutely a council must understand their contribution to a flu pandemic. Operation or exercise Cygnus that started in 2011, I think, exposed some of the frailties of that, and that exercise continued for a number of years. So councils would have had a response to a flu pandemic, but it wasn't a flu pandemic that caused, such disruption as COVID-19.
Let me pause you there. What, in fact, is a business continuity plan, and how does it differ from a pre-pandemic flu plan?
So imagine I'm in a local authority. One of the national threats, for example, is a cyber attack. It's really important that councils understand how they're going to mitigate that threat, and they will have a plan in place. If, unfortunately, that threat materialises, then councils should also have a business continuity plan. So if the cyber system knocks out all of your IT, there must be a mechanism to be able to meet your needs. And that's what is defined in a business continuity plan. That would be the same in a care sort of scenario as well. And we make contingencies in that context. So you would have a national risk plan, a council risk plan, you would have a plan for dealing with a pandemic, you would have a plan to manage the consequence if that pandemic sort of landed in your place. So
Right.
I hope that's useful.
Can I ask you this? Is a business continuity plan often incorrectly termed a contingency plan? Are they used interchangeably?
They are, sort of mistakenly.
Right, but they are different.
Yeah.
All right, so there's the business continuity plan, and then sitting under it, my
Yeah.
word, the contingency plans
Yeah.
for what you do if there is, in fact, a
Yeah.
cyber attack.
Yeah.
Understood. All right. Can I come back to the pre-pandemic flu plans then?
Yeah.
And we have heard from Minister Whately that she found it difficult to get hold of the plans. The two that she did see, she did not consider to be adequate. Do you know who was responsible at that stage for checking whether the pre-pandemic flu plan was fit for purpose as far as the adult social care sector is concerned?
So, accountability for ensuring there was a plan would sit with the LRF, it would sit with the Director of Adults, it would rest with the Director of Public Health.
And not only ensuring that there was a plan, but that it was up to scratch, if I may particular equally, was that also with the Director of Public Health and Director of Adult Social Services?
So it would be a sort of responsibility of the local resilience forum. Within a council, it would be Director of Adults and Director of Public Health, but a sort of governance framework should underpin it. I think the reality is for many organisations, flu plans were in place, but I feel I should say again, COVID wasn't, a flu plan. So I'm sorry that the minister felt the plans were unsatisfactory, but many of the plans were built and existed to deal with a flu pandemic. They didn't exist to deal with a novel coronavirus with completely different sort of transmission impact into communities.
Let me ask you that, understanding that they were effectively a plan for a different virus. Yeah. Clearly, we may not know what the next virus is that's coming. What is in place now so that there is perhaps a flexibility for the plan to either meld itself or adapt itself for a novel virus?
So at the moment, the Department of Health with the Cabinet Office are sort of working on a new sort of test exercise, Pegasus. Yep. And our understanding at this point is that that exercise will test a scenario that would see another respiratory virus be the one that would cause a pandemic, and will test a number of sort of transmission mechanisms. But as yet, that plan and that sort of risk assessment is not, I think, wholly in the public domain. So I think in local government, Pegasus and all the support framework around that is crucial to enable us to play our part in planning for the future.
So that's what I was going to ask you. Is the LGA, as far as you're aware, involved in Operation Pegasus?
We've had early engagement and will continue to make sure that we have full engagement on behalf of the sector, partly to come back to this issue about making sure that it's operationally capable and fit to deliver the response that would be needed.
Exercises are all very well if the recommendations are then implemented. You've already referred to one where frailties were exposed, operations or exercise sickness, and the recommendations weren't implemented. So how do we ensure that Pegasus recommendations are implemented?
I think there is a sort of different mindset now within sort of local government. The experience of running and living with a pandemic has made, I think, many senior officers very attuned to the importance of planning. And I think the lessons from sickness, but the lessons from COVID is about how do we make sure that there really are robust operational plans in place, and there is a mechanism for us to be held to account for that. I think one of the things that could be substantially improved is, Local Resilience 4 exists as part of the Civil Contingencies Act. It's making sure that the right people sit around the table when there is a hint of an emergency. So people with really strong operation experience with the accountabilities can sort of guide reaction locally, but also can help to plan, I think, through Pegasus now.
Can I ask you, please, about the lead up to the discharge policy from hospitals to care homes and the care sector more generally? And you say in your statement that the discharge policy and associated guidance was a key concern for the Local Government Association, and that in the beginning, in mid-February, the LGA considered the risk between not expediting discharges versus the risks in doing so once the patient had been discharged. And you say the LGA at that point did not have a definitive position on the balance of risk. Did the balance change, though, Ms. Killian?
So I think my statement is clear that it wasn't for the LGA to sort of prejudge any of the sort of medical advice that was emerging, both in this country and from the World Health Organization. It was a fast-moving new virus. I think our position was originally based on the fact that there is such good evidence that the longer someone stays in hospital when they don't need to be, actually the probability of them picking up a disease or losing sort of functioning increases. So really strong evidence, which continues to be the case today, that actually enabling people to be moved, if they're well enough, into their own home to be assessed against their needs is a really important feature of how we deliver social care in England. So it felt that some of those principles would be absolutely correct in this scenario, but only if mechanisms were in place to ensure that people could be protected, that as the days emerged, that PPE was available. So, our position on balance was actually people being in hospital might cause them to get coronavirus. It was our position that people that were vulnerable might need a bed. So it's on that sort of balance we thought with cautiously and with conditions enabling people to move out of hospital. But again, best practice is not about moving people into care homes when they do not need to be. It is about making sure that actually people go to their own home, and about 1% actually should have been admitted into care homes at that point. But there was some very long and hard and sort of difficult debates about that.
I think you say in your statement that the 19th of March discharge guidance, when it came out, was sent to the LGA at 4:17 on the 16th of March, asking for comments by 6 p.m. that evening. And you make the point it wasn't possible to respond within just over 90 minutes of notice, but the LGA did respond by midnight that evening. Can you help did you understand why there was such late engagement with the LGA? And perhaps more importantly, did the engagement improve over time?
So again, we recognise that this was a wholly sort of sort of incredible, difficult, sort of taxing, awful position for the officials to be in. And we recognised that they were working sort of furiously to be able to produce guidance. So we understood why things were being passed to us at one level so late. But on the other hand, it made it really difficult to get sort of considered responses back, to test with experts and professionals that we knew we had available. It was also frustrating for us to know that sometimes guidance was being passed to us to take a view on, but it was under a sort of secrecy seal that made it harder. But we worked as quickly as we could, recognising that everyone was under pressure at those moments during the pandemic.
I think you say in the statement that the LGA considered that March the 19th guidance to be acceptable, noting that it did not override a care home manager's right to refuse an admission. Does the LGA get any sense of how often a care home manager did in fact refuse to take a patient being discharged from hospital?
So we didn't collect data, and I don't think authorities did, but anecdotally, we know that there weren't sort of significant numbers of refusals. Many care home managers was incredibly sort of flexible and supportive, but recognising they had to protect people within their homes as well.
And you go on in the statement to say that it quickly became apparent that the 19th of March guidance was problematic at best and workable at worst. Your LGA's words. What was the problems from the LGA's perspective with the 19th of March guidance? And if it helps you, at paragraph 334 in your statement.
So we were concerned that, for a start, it felt it had been sort of lifted from a sort of hospital practice guidance. The reality is that care homes are run in a very different way. I think we were concerned that the model of discharge that we had endorsed or were familiar with made some assumptions about who would assess people to be able to leave. It was based on a model of really experienced assessors being able to make a judgment that people were fit to leave hospital and be assessed. And we were concerned that sort of professional evaluation may have been missed. It was also clear that despite sort of promises, the supply of PPE was not being made available. We were really concerned that, again, testing that had been promised was not available, and even where it was, results were not coming in. So there are a number of factors that gave us sort of cause for concern. But it's also true that we relayed some of those concerns on that piece of guidance and other guidance, and occasionally we were listened to. But I think over a very short period of time, I think there were 11 sets of different guidance offered out about the support given to people moving out of hospital. So it was really tricky, I think, for councils, but more importantly, care providers, to be able to interpret this and know how to do the right thing.
I think you say one of the problems with the guidance was the practical difficulty of isolating people in perhaps some of the smaller care homes. Can you help with any sense of scale of perhaps not necessarily the number of homes, but how much difficulty there was in England and Wales in isolating people in smaller care homes? We've heard, for example, people often had their own bedroom, but may have shared bathroom facilities, for example. Can you help us with how widespread a problem that is?
I can perhaps provide some supplementary information about the sort of the numbers of smaller care homes, but it's absolutely true that a significant proportion of care is delivered through small independent providers. So it may be a couple of big houses that have been knocked together. So it was just so impractical to think that it was possible to isolate people into their rooms, but into a wing of a very small building. It just was never going to work. Bigger providers in larger accommodation, there was more potential, but still really difficult to organise like that, particularly for residents who may have had dementia. It just felt like a very sort of severe thing and sort of impractical to deliver. But I'm happy to provide some sort of supplementary statistics about numbers if that's helpful.
Well, we know that on the 15th of April, the Adult Social Care Action Plan specifically stated that asymptomatic discharges should be isolated for 14 days. Was the LGA consulted in the run-up to the publication of the action plan?
So we did have engagement there, but again had concerns about how operationally sort of fit that was. There was an engagement group, there were task and finish groups running at that time, but I think our view was that things only materially improved when Sir David Pearson was brought in to provide that sort of leadership and professional knowledge to the programme.
Right. That action plan, I think, specifically stated that if appropriate isolation or cohorted care was not available to the local care provider, the local authority would be asked to secure alternative accommodation. And can you help us, Ms. Killian, what kind of premises were considered to be appropriate accommodation for someone who's being discharged from hospital?
So, the view of the LGA then and now is that the most appropriate place is for people to be able to return to their own homes, and that, I think, should have been a priority. It's also the case that the government wanted to explore the notion of sort of designated settings with sufficient capacity in designated settings in local authority areas to be able to support people. And progress was made on that, but again, that didn't feel like the most satisfactory solution.
We know
either.
that designated settings were effectively brought in from the late 2020 into 2021. But can I ask you, please, about an example that the inquiry has seen? Can I have on screen INQ 545634? This is in April 2020 from someone working in Telford and Wrekin Council. It's titled Hotel Care Home, anyone giving this a go. And can we see there was a quick call out to see if any of you are in the same place as me, which is about to commission our local Marston's pub and lodge to be a post-COVID community recovery setting for older people. We're taking a 28-bed hotel and staffing it with our own daycare support workers and cleaners. And then they go on and turning it into a domiciliary care, extra care, step-down hybrid for when the going gets tough. We're just sorting the specification for this now and have a draft project plan underway, but could do with a critical friend in the same boat to talk about this. It may to some people sound pretty horrifying, the idea that people are going to be discharged to a pub/hotel. Does the LGA have any views about whether that was in fact an appropriate setting for discharged patients?
So I think sort of councils with other statutory partners were really sort of thinking about all the options to keep people safe, triggered by the requirement of the April the 12th guidance. And I mean, I read this and I can understand why people might be concerned about this as a model. But there was, I think, some careful thinking about whether other settings would be appropriate to enable people to leave hospital and avoid having to go into a care home. I think the ongoing sort of flaw in all the plans was the lack of testing, the lack of understanding of the transmission. But to be fair to my colleagues, it was so pressured and colleagues really wanted to enable people to be in safe spaces. But this is not an ideal way, is it, managing that?
I think, more generally speaking, one of the concerns of the LGA was issues with the lack of PPE and indeed the lack of suitable PPE. And can I ask you about that? And you can take it as read that we're familiar with the worldwide clamour for PPE, if I may put it like that. But I think in your statement, you make reference to the fact that PPE was diverted to the NHS, and indeed the survey found that 42% of respondees said PPE was diverted either very often or fairly often. We've heard a number of pieces of evidence on a similar theme. What did the LGA do when it started to learn that there was certainly a belief by some, if not the reality, that PPE was being diverted or prioritised to the NHS?
So for me, I think it's going sort of back to a principle. In the early days of the pandemic, colleagues in social care were just not prioritised for PPE. It was the case that many care homes, have made use of PPE in their operations pre-pandemic, but they would never have been keeping sort of stocks to the level that was required during the pandemic. So from lots of intelligence gathering that the LGA did, it was clear that this was a really sort of significant and urgent problem. It was a problem for frontline care workers. It was a problem for, experienced social workers that should have been in homes being able to support people. It was a problem actually for CQC not being able to have PPE to be able to go in and make their assessments. So our experience from the LGA point of view was, despite, very clear stories that PPE was available, it just wasn't. And from a very personal point of view, I remember chairing a gold meeting one Sunday night, relatively early into the pandemic, and it was a gold meeting that covered the needs of hospitals as well as local government and other bodies. There were just no gowns available. There just wasn't PPE available in any sort of levels to support the functioning of hospitals, let alone care homes. And it was a very difficult moment just to sort of work out how do you allocate the very small number of products that we had. So we absolutely acknowledge that the government sought through the sort of national supply disruption route model. They did deliver drops through LRFs to enable care home provision, but some of the drops were wholly inadequate, not fit for purpose, and LRFs were sometimes hampered because they didn't have the information about where to drop.
All right. Can I just ask you there, when you say that some of the drops were not fit for purpose, they didn't contain enough stock, or the stock that they did contain was poor quality, or both? Can you help?
Stock volume that we had been promised did not arrive. So we might have been told we'd get, 50,000 products. I remember vividly, opening the box or opening our container, and it might be 1,000 products. Some of those were out of date. Some of those were not fit for sort of medical or care use. The Clipper service came online, I think, in May or June of 2020. And again, that was designed to be, a call-off arrangement that would allow providers, local government to go directly into the Clipper system. And things were improving. But even then, again, anecdotal but strong evidence that call handlers, the email processing, again, saying actually we can't provide what you need today because we've got a supply problem, the NHS has to be prioritised. So, things did improve, but not quickly enough to be able to meet the needs of all providers.
Can I come back to the, you mentioned the LRF drops,
Yeah.
and we know there were a number of emergency drops,
Yeah.
I think from March onwards. One of the things you say in your statement at paragraph 553 is that the emergency planning had set out the expectation that upper tier authorities, what are they please, Ms Killian?
So upper tier authorities are county councils, city councils, London boroughs.
Thank you. That those upper tier authorities would play a role in the distribution to social care staff of face masks from the national stockpile. However, at short notice, the LRF route was introduced. And there's a sense in your statement that that was perhaps, that change in the plan was perhaps not the most helpful. What practical difference did it make to change from having the upper tier authorities distributing to the LRFs doing the distribution?
So individual authorities would absolutely know their care providers. They would have had intelligence about what needs they may have had. LRFs cover sort of wider geographies mostly. So an LRF might cover, say, 3 or 4 big single-tier authorities sometimes. In my case, in Surrey, we had a coterminous LRF and county council, and that made mechanisms easier, actually.
One of the suggestions that we have heard is that local authorities should hold a stockpile of PPE. Is that something that you would recommend? Is it realistic?
So a number of authorities would have held PPE prior to this pandemic, but again, their stocks, had they had them, would have been based on assumptions about a flu pandemic, and therefore had a smaller level of stock. I think the issue is the importance of the nation having a supply chain that can be drawn down in the event of this crisis. So it may be that, you know, local authorities can hold it and can distribute it, but the fundamental problem was the lack of supply.
Can I change to a different topic, please, and changes to the regulatory inspection regime and indeed the impact of that on safeguarding. And I think you say that the LGA did not raise any objection to the CQC pausing routine inspections, given that there was the emergency support framework in place to act as either intelligence to monitor risk or indeed to support care home providers that needed some assistance. But there was nonetheless some concerns, I think, of the LGA about the ceasing of routine inspections. And what were they, please?
So, I mean, CQC's function is very much about sort of operational safety, care for people in residential settings. It's a really important tool. And, you know, CQC deliver both planned inspections, but are available if there are enough alerts or signals from a place that would cause it to think there was a breakdown in care provision. So our initial concern was, you know, making sure that where there were safeguarding concerns, that there were mechanisms available. As a local authority, you know, there are statutory duties to make sure that adults are safe and protected, and we were concerned that that initial lack of sort of intelligence gathering have been a deficit. However, as the pandemic progressed, I think local government with its partners, its statutory safeguarding partners, put in place some really strong mechanisms to assure itself that actually people were being protected and sort of safeguarding threats were recognised and dealt with.
I think I want to be clear, there's obviously concerns once those inspections were suspended that there may be safeguarding risks. Yeah. But does the LGA have any detail about what actually materialised and whether there were, in fact, very real safeguarding cases that were brought to light? It's a concern is one thing, but did it actually happen, I suppose, is really what I'm asking you.
So there were some concerns, I mean, both in relation to older people, but actually to other vulnerable groups. So reporting levels did increase, for example, for women, for example, you know, who had been in domestic settings at threat of harm from their partners. So for a while, referrals about care homes issues dropped, but we did see an increase in sort of vulnerability about people being in their own homes without sort of support as well.
I think in your in the survey, if I can have up on screen, please, INQ 400 522 _83 and then into 84. The survey asked about this, and the bottom section there, the authorities were generally supportive, they were asked how supportive were you or not of the Care Quality Commission's decision to temporarily suspend. Generally speaking, you can see there 26 and 54% were very or fairly supportive in England. Higher figures in Wales, where they were very and or fairly supportive, is 91%. And then if we go perhaps to the next page, how do you feel the suspension of inspections of care homes, do you feel the suspension of inspections of care homes had a negative effect or not. In England, yes, 43%. In Wales, 32%. And then perhaps slightly different figures for the no's. In England, 36% of authorities felt it had a negative effect, 59% in Wales. So quite mixed views there about that. What was the overarching concern, though, from the LGA's perspective about whether there was a negative impact on safeguarding or not in care homes?
I think our view was also based on the fact that we knew and we know that actually suspension of visitors into care homes was a problem. You know, relatives, friends visiting, they will often, in the small number of circumstances where there is abuse or harm, they will often spot signs and signals. So for us, yes, we had concern about suspension of inspections, but we were also concerned that actually the mechanisms to understand potential harm was being sort of blocked in this dimension as well. The fact that community health visitors at the beginning were not permitted into homes as well. But, you know, the relationships between councils and providers are strong. I think many councils would have picked up the phone, you know, providers would have rung if they had felt that they were concerned. There was a variety of other mechanisms to sort of pick up concerns aside from CQC. The issue about not having inspections was also a concern, I think, from providers that if their ratings had been required improvement or, you know, inadequate, there was no opportunity for them to sort of be seen to have improved their services at this time as well.
I think one of the insight reports that was conducted in 2020 by the LGA, can I have up on screen, please? In fact, Ms. Killian's statement, INQ 587382_200/201, considered why there may have been an increase in safeguarding concerns raised in the second half of 2020. And you set out there that it was attributed to different factors, and I'm not going to go through them all, but if we could perhaps just scroll down to the bottom bullet point. There was concerns that the rise in safeguarding concerns in the second half of 2020 was in part related to staff not wearing or inappropriate use of PPE. From the LGA's perspective, do you think there was a need for inspections to continue to perhaps ensure that staff were either wearing it or that indeed the PPE was fit for purpose?
So CQC's regime looks at a number of factors, including how safe care is delivered. So they may have well been able to sort of pick up this use of PPE in their inspection. But I just think there are a number of other factors that cause some areas of potential concern.
Just standing back from a moment, does the LGA have a view now on whether the decision to suspend routine inspections was the correct one and should be in a model adopted in the event of a future, perhaps, respiratory pandemic?
So, you know, inspections take time to prepare for, and if done sort of correctly, you know, will look and sort of establish great things that are happening as well as sort of defects. So if there could be safe provision for inspection, if they could be proportionate to the environment that we would find ourselves in a future pandemic, absolutely yes, because they're an important way of gathering information. But it's also true that people were protected for, you know, through other mechanisms as well. I think for us, you know, inspection is important, but it's not the only mechanisms to ensure people are safe in care homes or their own homes.
Does the LGA have any view on whether a hybrid model, perhaps of some remote inspections, some in-person inspections, might perhaps redress the balance in some way?
So, I mean, hybrid activity did take place on the part of CQC, but also other safeguarding partners that are crucial. And there's some really fantastic examples of that. hybrid is fine, but at the end of the day, I think great inspectors, can understand and sort of see and feel how it is to be in a care home, doing well, but doing less well. So I think eyes and ears in a place is crucial, actually.
Slightly different topic in relation to the Infection Control Fund. And certainly there is concern that perhaps the Infection Control Fund was not being used to ensure that staff who were isolated received their normal wages, which was one of the main aims of the ICF. Were the LGA aware of problems with the ICF not being used for its intended purpose?
We weren't. We understood why the government sort of chose to put in place quite sort of onerous grant conditions, including concerns they had about state aid, like proper use of money, ensuring it was directed. So we could recognise why those grant conditions were in place. We didn't feel concerned that money was being diverted to inappropriate areas, and indeed there was a lot of bureaucracy to complete those grant requests, and we understand that the Department of Health and Social Care has since audited all of that work and are content that it was spent correctly against the grant conditions.
Ms Whately told us that accompanying certainly the publication of the Infection Control Fund package, she included in reference that there should be a care home support plan put in place by the end of May 2020, which should be made public. From your perspective, perhaps indeed even as a chief executive of Surrey, what did you envisage those care plans would include or might include? And do you have any views about whether it was necessary for them to be made public?
So there was a requirement to produce a plan, and indeed sort of grant release was dependent on having those plans. I think the vast majority of plans were drawn up in good faith and talked about how they would support people in care homes, the expectations they had about people being safe, the really good work that was happening then with providers, including support to the workforce, including additional payments that were being made. One of the positive things actually about those plans, if you look at them now, they sort of illustrated really sort of positive, like good work to make sure that people were safe.
Can you give us an example, practically?
Yeah. So, for example, support being given into a particular sort of care home where, I'm just thinking of one now, support being given into a particular care home where, for example, sort of cash flow was problematic, and there had been a really good sort of debate with a provider about actually the value of being able to sort of forward fund their work, not least to be able to invest in sort of workforce reform. So, I mean, these were expected to be dynamic plans, and I think in part, they also illustrated the continuing sort of financial pressure that those providers were under. I mean, there was some hesitancy about the plans because, again, the focus was on care homes, where many of our members were saying, actually, we've got to be able to support people living in their own homes, the carers supporting those living in their own homes as well. So it felt slightly unbalanced, but that's where I think the government continued to think the risk was.
Can I ask about a few discrete topics,
yeah,
please, Ms Killian? And in your statement, you make reference to the disproportionate impact of COVID-19 on black and minority ethnic individuals and indeed migrant workers. And her ladyship's familiar with the Public Health England Disparities report that came out in June 2020. But can I ask, what did the LGA do in response to the growing awareness that there was this disproportionate impact on a number of members, particularly of the adult social care workforce?
Yeah. One of the roles we have is about support into councils on really sort of sensitive issues like this. So part of our role was hearing back from the sector about sort of the incidents and the prevalence of this really sort of profoundly distressing issue. we encourage councils to think about, in their places, how would they work with health partners to prioritise, say, vaccinations for people from BME communities, to make sure that vaccination programmes, prioritise the needs of those people, that where possible, there were, plans in place to deliver those. I think councils were also concerned more broadly about the impact that of COVID on BME communities. So some really fantastic examples about councils working in partnerships with faith groups, for example, to encourage vaccination take-up, to encourage testing, which also I think had an impact on sort of the workforce. But I mean, the legacy in this area is really bleak. So working together, I think, as we think about the next exercise, about how we really do sort of protect those groups of people and enable actually people to self-isolate. And I think that was a really profound concern, that some of the members of those communities just didn't feel empowered to be at home or supported.
Perhaps one of the other bleak areas, to use your phrase, was the measures in place to notify DHSE if a care worker had died. And you say that there was a manual process in place, but that the LGA considered it was unsatisfactory. Does the LGA have any suggestions for how notification of adult social care worker deaths could be improved?
I think we were concerned that just having a sort of email and directing people to respond to an email and not actually being clear about what would happen, was our concern. Many people lost their lives, our workers lost their lives, and it was important to have the data to be able to make a difference in the future, but we were just concerned that an email just might drop nowhere and nothing happened. So there has to be a better system, I think, of understanding which groups would be affected in the future, and a better way of recording that sort of dynamically.
And to be collated by who? The Department of Health and Social Care, MHCLG as was?
I think it's important that, this is about sort of local intelligence. Some of our councils serve highly diverse communities, and they should have that data. It should be collected, I think, by Public Health England, because they can sort of think about what the response to that should be. But throughout the whole of this incident, the issue about sort of data collection, data ownership, the value of data, I think, made things more difficult for all parties, I think, whether it's on this issue or many others.
I've asked you a number of questions about care homes. Can I ask you about unpaid carers, though? Yeah. And in your statement, you say that one council described the impact on unpaid carers as, quote, intolerable, where carers were caring without a break, in addition to them providing childcare and supporting the person they were looking after. What role, if any, does the LGA have in trying to support unpaid carers?
Yeah. Councils have a duty to assess the needs of carers, and that is a really important duty. We have millions of carers in this country. Through the pandemic, I think their contribution just wasn't recognised sort of nationally. But from an LGA point of view, we were working with councils who were trying their best to be able to support carers, where organising colleagues from the voluntary sector to step in to support, organising food parcels, beyond the point when government was funding it, trying to do assessments. But I think, again, the legacy for unpaid carers is a long-lasting one, and again, it's something that has to be understood and corrected for the next pandemic. The levels of isolation, the impact on their mental health, I think is still to be discovered.
Can I ask you, please, whether the LGA considers that a register of the adult social care workforce would assist in the event of a future pandemic, and if so, in what ways?
There are, at the heart of this is the importance of ensuring that care workers are recognised as a really strong, capable profession. if registration enables that, if registration as part of a new employment and career structure is important, then we would absolutely endorse it. On the other hand, I think we have concerns that a sort of onerous bureaucratic registration system would force people out of the market. So we are keen that through the case review, actually talk to workers about what they want in the context of workforce reforms that the government are putting in place now.
Final question, please, and it just picks up on what you mentioned there about recognition. It's a word that Her Ladyship has heard mentioned a lot. And in fact, I think Helen Whately told us that she felt there was certainly an increased focus on adult social care, that there was an increased understanding by people of the need for recognition of the work that the adult social care force did, but perhaps that it might have slipped down the agenda. Do you agree that perhaps there isn't that focus now on adult social care and we've returned to pre-pandemic ways?
I think in many ways we are where we were sort of pre-2020. The only change is work that's been done on sort of workforce reform, but I think as a society, in government, there's just still a really fundamental lack of understanding about how we support older people, those with learning disabilities, for example, to live happy lives. I think we have not made the progress that I and others would have wished.
I'm sorry to end on that note, Ms Killian, but that is the final question I have for you. There are some core participant questions though, my lady.
Thank you. Mr Weatherby, just there.
Thank you very much, my lady. Good morning, and I ask questions on behalf of COVID Bereaved Families for Justice UK. And just one point from me, and it's relating to visiting restrictions, and it's something that you've touched on already. At paragraph 573 of your statement, you say, and I quote, "The LGA held significant concerns over the impact of visiting restrictions on recipients of care. The restrictions separated clinically vulnerable people from their loved ones, leading to incredible trauma and grief as people died alone or suffered from loneliness or sadness at the absence of a loved one's touch," unquote. Does the LGA believe that government restrictions and guidance got the balance right between visiting restrictions as an IPC measure and supporting the well-being of residents and their families? And if not, what should we be doing in the future?
Yeah. So I should start by offering my condolences to your families and also to sort of recognise the pain that people are living with now still,
Yes.
post-COVID. I think sort of my statement is really clear about how difficult it was. I think from sort of very first-hand experience in my role in Surrey, it was heartbreaking actually to sort of see the impact on relatives and those living in care settings that they couldn't see their loved ones. I think, the science wasn't clear, but on balance, for a future pandemic, it cannot be that people are separated. I think the trauma that families face now, the trauma of people not being able to see their relatives, and I sort of experienced that myself, it was sort of inhumane. So I think that really does have to be a different way of protecting the most vulnerable, but ensuring that they can have the most important thing to them, which is like love, basically.
Yes. And how do we do that?
So I think we've got to really work hard through the sort of planning that we're doing now on a future pandemic. I think we've got to think again about how we do deliver sort of safe, protective care. We've got to think again about, whether it's right in that scenario to place people in homes. It should have been in their own homes where love can, that sort of relationship can be formed. So I think, we've got to work with the science, but I think we've also got to sort of remember what matters to people. And so a whole bunch of objective tests have to be met. But I think, we've got to have a better way of engaging with people who've had the experience, engaging with people that are living in sort of residential settings and talking to them and planning and co-design work, which I think could have made a difference, actually. I think people were so shocked and stunned about the sort of instant, you know, we're going to stop visiting. I think it was terrible for people.
Thank you very much. My lady, my other 2 points have been dealt with. So
Thank you very much, Mr. Weatherby. Very grateful. Now it's Miss Jones, who's over that way.
Hi.
Thank you, my lady. Ms Killian, I asked questions on behalf of John's campaign, the Patients Association and Care Rights UK. And I want to ask you about the support that was given to care providers to meet their legal obligations. Firstly, and related to the question that Mr Weatherby just asked, statutory guidance under the Care Act confirms that the well-being principle is a guiding concept, and it places individual well-being at the heart of the provision of care and support. Can you explain what steps local government officials took to ensure that well-being was properly considered during the pandemic?
Yeah. So, I mean, I'm assuming there's been a lot of discussion here about, you know, the functioning of the Care Act. But at the heart of the Care Act and other supporting legislation is this sort of driving principle about people being supported to be independent and live well, and for prevention to be in place to ensure that people can live sort of happy, healthy lives as long as they can. So I think genuinely through the crisis, councils absolutely in thinking about support for not just older people, but a variety of other people, was about protecting their well-being. And sometimes that absolutely was about their physical well-being, but an awful lot of support went into enabling people to sort of cope and to address, I think, poor mental health that was becoming obvious through stages of the pandemic. So I think where councils had a very specific duty to an individual, of course it was about protection, but I know, including from my previous role, the importance that councils placed on making sure that, you know, people could cope as well as they could. So for many councils, as well as sort of delivering on their sort of statutory duties, did a huge amount of work in terms of welfare support, working with the community and voluntary sector to support people in their places, including people living in their own homes, provided food packaging, you know, delivered sort of online sort of conversation support. So I think the wellbeing principle was, you know, in the minds of social workers making their assessments as well as it was for councils. But it was tough to do that, you know, consistently in a circumstance where, for example, you know, people couldn't see their families.
Was the conflict that arose between different aspects of well-being, so the physical well-being that had caused the introduction of things like the visiting restrictions, as compared with the more holistic view of well-being as we came to understand the damage that those restrictions were having on people? Was that conflict something that you at the LGA were discussing with people or had ever had to balance before?
I mean, I think sort of conflict is a sort of difficult word. I think many colleagues in local government, individual social workers, care home providers were genuinely trying to sort of balance keeping people safe, some of the most vulnerable people safe, based on evidence that was emerging from, you know, Public Health England, from the Chief Medical Officer, in trying to balance that immediate protection against sort of the wellbeing principles. And I think as the pandemic progressed, I think, you know, more and more people believed the need to get those two in sync was imperative. But I think it was really hard at times to do that, including for people that had to self-isolate. These were very restrictive, you know, bunch of arrangements that people had to live with. But I believe strongly that, you know, staff, both commissioners and providers, really wanted to do the right thing consistently, and sometimes it was just tough to do that.
Thank you. And then can I ask, what, if any, steps were taken to support care providers in taking individualised approaches to people who need care, rather than imposing blanket restrictions?
So, I mean, in the early days of you know, the pandemic, I mean, we've talked earlier about sort of multiple sets of guidance that was available, but as things ease, I don't mean ease, as things sort of changed, I think a number of providers went above and beyond to absolutely sort of tailor and individualise packages in the context of the provisions that were available to them. And people that run care homes know exactly, I think, about how they should support individual needs. And I know that they work really hard to meet those needs in the context of the arrangements that were being forced on them, I think.
Thank you. Thank you, my lady. Those are all my questions.
Thank you, Ms Jones. Ms Beattie. Ms Beattie's over that way.
Thank you.
Ms Killian, I ask questions on behalf of disabled people's organisations. And can I ask you, please, about easements and when they were acquired and when they could otherwise be avoided under the existing Care Act framework? At paragraph 669 of your statement, you say that most councils were able to find sufficient flexibilities within the existing Care Act framework to avoid the need to make use of easements. Is it right that flexibilities in this context is about how eligible needs are met, but not whether they're met?
So, I mean, the Care Act duties are clear, and councils knew they had to meet the needs of individuals. Sometimes it was more complex to meet those needs if, you know, day centres, for example, were shut or there weren't provision in some bits of the sector. But I'm absolutely clear that, you know, local government absolutely knew it had to meet duties towards individuals and delivered that.
So when you use the word flexibilities in your statement in that way, you mean that councils still met the eligible needs, but did so in a different way because the usual means were unavailable, for example?
Yes.
And just to put that into concrete terms, and you've mentioned day centres. So if, for example, someone had an eligible need of meal support or provision, and they would normally get that at the day centre that they attended, and that was in their care plan, but the day centre was closed, an alternative could be obviously to provide that meal at home or make some other arrangements so that that need was still met. Would that be right?
Precisely, yeah.
An easement, though, would be required, and just to be clear about this, for streamlining of services instead of providing a genuine alternative, is that right? Or reducing care to a person that's provided under their plan?
So the matter of easements is a sort of contentious one. Local authorities are and remain clear about the importance of delivering for people's needs. To even contemplate an easement was a big thing at that time, and it was about, I think, publicly saying, actually, we're going to have to sort of think about how we deliver needs. I honestly do not recognise the council saying we're not going to meet the need. It was about how we would do it differently, but still meeting the needs that an individual had.
So, Ms Collins, so just to go back to my question, the streamlining of services as opposed to providing an alternative or actually reducing care would be an easements territory and require an easement, is that right?
I'm not sure about the sort of language of streamlining.
Okay. I think the LGA and ADAS produced some guides, I think, for local authorities for to explain the easements. Is that right? Some joint guides, and that said in terms that streamlining and reducing personal care for a person would be in easements territory. Is that right?
So, I mean, we sort of commented on guidance, and I just feel I'm going to repeat myself again. I mean, the importance was about continuing to meet needs. It might have done it differently, and extremists, you know, may have had to acknowledge, you know, I think in your language, a sort of streamlining. But I think all councils knew they still had to sort of meet needs effectively.
And if that document confirmed that that streamlining or reducing care was in what was called stage 3 or stage 4 of easements. That was definitely easements territory, wasn't it? Stages 3 and 4. So again, for example, cancelling home care visits to assist someone with hygiene or toileting needs contained in a care plan and not doing anything in substitute to meet that need would again be in easements territory, yes?
Yeah.
And is it right that at the time during the pandemic, local authorities were not under a duty to report replacement services or flexibilities, if I can put it that way, to central government, but they were required by the guidance to report easements? Is that right?
Report incidents. Sorry, I didn't get the last bit.
Sorry, to report easements, to report their use of easements.
Yes, there was a requirement. If an authority took a decision to report an easement, then that has to be put into the public domain, registered with CQC.
Not just if they took a decision to report it, but if they were at stage 3 and 4 and using easements, they had to report that, didn't they?
Yeah.
But at that time, the Part 1 of the Care Act duties, which include some flexibility, were not subject to any reporting or indeed regulated inspection by the CQC, were they?
Sorry, I'm not sure of the point, sorry.
Well, I think, are you aware that since April 2023, the CQC has had a role of conducting reviews of regulated care and functions by local authorities? That wasn't in place during the pandemic time or during easements time. So flexibilities weren't required to be reported, but easements were. Is that right?
I believe so, but I will absolutely clarify the sort of your language of flexibilities versus easements.
Okay, well, I think it's, Ms. Killian, you had used the word flexibilities as saying that's what you said most councils had done during the pandemic.
Yeah, it's recognising to meet a person's needs, during the time of the pandemic, not all facilities or options were open, so needs were met in using sort of different tools or different approaches. So that's my sort of language of flexibility. I think, invoking a sort of easement was something that councils considered very carefully and had reporting requirements attached to it.
Do you think that the organisation Think Local Act Personal was right in their report of October 2020 that there were different approaches taken by local authorities across the country, with some using what they called so-called flexibilities and some using easements, such as there was what they described as the very grey area between the two?
So only a very small number of councils chose to invoke easements. Local authorities deliver care to very different communities in different ways across the country. It's very different delivering sort of home care in a rural area versus delivering home care, say, in a city. So inevitably, care packages are built on the basis of what people need, what's available in their communities. And I think that sort of publication partly sort of highlights the difference that have always existed. And I think drew a sort of line about how different easements were. So I'm sort of familiar with that. I think the language of sort of a grey area, again, is not helpful in that, councils do have packages built to meet the needs of their communities. They are not sort of one-size-fits-all packages, but absolutely the duty to deliver care is paramount.
But is one of the consequences, though, that we are now left without a complete and comprehensive picture of how care plans were subject to replacement services under the Care Act, or actually being eased and reduced and streamlined in stages 3 and 4 territory of easements?
So I don't think there is one single record that sort of sets out for every recipient what sort of care package they got, pre the pandemic, during the pandemic, and for those small number that were affected by sort of easements. We don't have a single record.
And it may be obvious, but do you accept that a system can't rely on individual disabled people who are care recipients of care plans to make complaints or even commence litigation to establish whether or not the local authority services being provided during the pandemic were being provided flexibly or actually reduced.
Sorry, can you just say the question? I can't hear brilliantly.
But basically, the individual recipient of care or their loved ones can't complain about the level of care delivered in the care package.
So I think, you know, disabled people and other people, I mean, absolutely have a right to be able to express the concerns about the nature of care that they were provided with. And there's a number of routes into local authorities to trigger alerts if people are concerned through a sort of section 42 and through to the CQC. So there were mechanisms then, they exist now.
Yes. In a pandemic, though, it wouldn't be right, would it, for a system to rely on individuals isolated in their homes in pandemic circumstances to make such complaints in order to find out and gain a systematic oversight of what was happening in care plans, would it?
It wouldn't be right for individuals to feel that they have to do that, no.
And is that all the more so in a situation where the emergency law itself brought in for COVID, the Coronavirus Act, had altered what were the usual duties to provide and meet needs into a discretionary power? So changing those goalposts, if I can put it that way.
So, I mean, I think it's really important to say, I mean, the easement provision was there, it wasn't used. You know, authorities wanted to continue to deliver the best care packages they could in the circumstances that were there and present.
And is it right that there...
Sorry, Ms. Beattie, I'm afraid that we're going to have to leave it there.
OK, thank you, my lady.
Thank you very much. Those are the questions we have for you, Ms. Kiernan. Thank you very much indeed. I'm sorry we had to take you back
That's okay.
through what was obviously a distressing time for everybody concerned. But thank you very much for your help. And I don't know how much of this very lengthy statement you produced and how much your colleagues did, but could you thank them for all the help that they've given to the inquiry as well? I've got a feeling we may be asking you for more help in modules to come, so I can't say goodbye, but thank you for the help you've given so far.
Thanks very much.
Thank you. I shall return at 10 to 12.
All right.
Ms. Paisley.
My lady, the next witness is Dr. Maria Rossi.
Right, repeat after me. I do solemnly,
Sincerely and truly declare
and
affirm that the evidence I shall give
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
the truth.
Good morning.
Morning.
Dr. Rossi, thank you for attending the inquiry today and for providing your statement to this module dated the 2nd of April 2025. That statement has been co-signed with Paul Johnson, Chief Executive Officer of Public Health Scotland, and Scott Held, who is Head of Data and Digital Innovation. And the inquiry understands that they assisted in the production of the statement. Is that correct?
Yes, thank you.
Briefly, please, dealing with your background, you hold a Master's in Health Services Research and Public Health Epidemiology, and since 2005, you have been registered as a UK specialist in public health medicine. You joined the pandemic effort at Public Health Scotland in March 2020, where your main areas of work were in response coordination, including adult social care and general liaison with the Scottish Territorial Health Boards, the other UK public health agencies and the Scottish Government. And presently you work at Public Health Scotland as Head of Division for Environmental and Emergency Response in the Clinical and Protecting Health Directorate. Is that all correct?
Yes, and I also have a medical degree from University of Rome.
Grateful. Thank you. Public Health Scotland is an NHS board sponsored by the Scottish Government and the Convention of Scottish Local Authorities on behalf of local government. It is Scotland's national public health body, which leads and supports work across Scotland to prevent disease, prolong healthy life and promote health and wellbeing. Is that correct? Can you assist, please? How did its joint accountability to both local and national government work in practice throughout the pandemic?
So the dual sponsorship to Scottish Government and COSLA is important because public health is actually an area of a discipline of medicine, but also an area of other work that has to encompass both health and social care. And we work with government, working on policies, advice, etc., particularly during the pandemic phase. Therefore, it's important that that sponsorship that was there at the start of our organisation from 1st April 2020 made an important contribution to ensuring that that happened.
The inquiry is familiar with the establishment of Public Health Scotland in April 2020 and the retention of the antimicrobial resistance and healthcare associated infection, or RHI, within National Services Scotland. But I just have a few questions, please, focusing on the scope of this module. In your statement, you say Public Health Scotland would acknowledge that the coincidence of the start of the pandemic with the establishment of new organisations caused challenges in how it responded to the pandemic. And if we could have on screen, please, INQ 305866047 at page 2. And this is an email dated the 23rd of April 2020 from Dr. Ramsey, who was then the Strategic Incident Director for COVID-19, to Angela Leach, who was the then Chief Executive. And he said, this is an update on developments in relation to the PHS work on the care home situation. The number of people in PHS involved in this work has escalated, resulting in a lack of clarity in terms of who has overall responsibility and leadership. I have therefore tried to clarify who within PHS is involved in this work associated with the care homes issue and to address how this is being coordinated. And then scrolling down a bit, it says, in view of the increasing complexity of roles in PHS in relation to this topic and the risk for confusion on overlapping work, I called a meeting this evening with Scott Howard and others to discuss the situation and to try to clarify roles and responsibilities. Were those the sorts of challenges experienced at the start of the pandemic?
Yes, so this relates particularly to the situation within Public Health Scotland, but in the pandemic, of course, we had to and wished to work in collaboration with many other agencies. So having a focus within PHS for the likes of care homes was important, and my colleague Dr. Ramsey was pointing this out as an issue towards the beginning of April.
And in the view of Public Health Scotland, did this cause any difficulties prior to the 23rd of April?
I should premise that I joined in towards the end of March, but I'm aware that, well, generally, health protection and public health generally are very used to working across organisational boundaries, team boundaries and topic boundaries. So this wasn't an unusual situation to have to work in the pandemic with multiple agencies and organisations. So whether at the start of a pandemic, an unusual event, obviously there is a lot of organisation that goes on in setting up a response, which has to happen in very short time. And Public Health Scotland, or Health Protection Scotland, as it was prior to 1st April, had the Incident and Emergency Response Plan in place. And when the determinations were made, I believe in late January, that this required that type of response, that process kicked into place.
And do you think that there was some confusion until the time of this email?
I'm not sure I would note it as confusion. There were many people involved in doing a lot of work in very short timeframes. So the coordination of that was important and needed to certainly settle at the start. And it took a while for that to settle, mainly because the issue of care home situations had to, by its very nature, involve many agencies. So we didn't have specifically a care home group in Public Health Scotland before the pandemic.
We'll come on to that, please, in just a moment. But if I can look at the response of Angela Leach, please, who said, thanks for this update. That sounds much more joined up than had previously been the case. So do you think that there was further clarity beyond the 23rd of April? And do you think the organisation perhaps got a grip on that clarity early enough?
Yes. by way of example, and Angela Leach, as our chief executive at the time, would have been going to certain meetings, covering certain meetings that at the last minute, and with perhaps colleagues in the health protection area that weren't with her, or possibly sometimes not able to brief her. And the impression that she had wasn't surprising. But it must be said that during pandemic, this sort of thing did happen recurrently because there were so many entities that had to play a part in it. And I think she's highlighting particularly in this email from Dr. Ramsey, between Dr. Ramsey and herself, the issue, for example, of data. When there were many sources of data, everyone trying to put something together in order to support the care home situation, and that's being reflected.
Can I ask you to slow down?
Sorry,
I know it's
thank
difficult.
you.
Don't worry, I have a fast speech pattern too, but we've got a stenographer struggling to keep up.
Of course, apologies.
Thank you, my lady. And something you've just touched upon, you explain in your statement that there were corporate arrangements put in place in Public Health Scotland to drive its response to the pandemic. And you say it should be noted from the outset, none of the corporate groups in these arrangements had a specific adult social care focus. Was that an oversight, or was there a particular reason for that?
A pandemic response has to be ready for anything that arises, and care homes, although an important setting, particularly by way of the nature of the virus, the novel virus that was coming on board was particularly vulnerable. There are a number of settings for which we couldn't, in anticipation, set up processes or pieces of work or individuals dedicated time against for all the time, nor could we always foresee it. So this is not something unusual in emergency response, but an organisation like PHS needs to be prepared to get that coordination into play relatively quickly, and perhaps that's where PHS, being a new organisation, had a particular challenge, I guess.
So in the future, is there a specific corporate group that would be set up to deal with that sector?
So we are looking at that, and certainly that has already started in the area of data, in the data and digital innovation team that Scott Heald leads. There's already been a review of care home data that has looked at multiple sources of information that can inform the care home situation, and that's even out with the pandemic, but ready for any sort of crisis that could arise.
Are there any lessons in particular to be gained from Public Health Scotland's initial structure over the first few months of the pandemic that could be taken forwards as learning for a future pandemic?
So the 1st of April had been set as the start for PHS many months before, I would have thought even a year before. And so in the ensuing time, there was much preparation going on for the new organisation. I guess that elements of Health Protection Scotland, as was, got somewhat deviated from the attention of that from December, January of 2020, and therefore that might have taken away from the health protection element of it. But I think that there are many lessons that we have learned and taken on board from that, and still working to improve on coordination, particularly with external partners, and some work also internally.
And then one final comment, please, from Miss Leach on this email. And she says, I had asked an individual to coordinate to avoid the confusion that was played out at the meeting with DPHs yesterday, but I understand from speaking to her that she hadn't been able to make the connections necessary. Is DPHs, is that a reference to the Directors of Public Health?
Correct.
And can you please help? What was the division as between Public Health Scotland and the Directors of Public Health insofar as the pandemic response to the adult social care sector?
So the Directors of Public Health are directors in each of the 14 health boards in Scotland. They report through their chief executives directly to Scottish Government and are accountable. That's the pathway of accountability. Public Health Scotland is an organisation in itself, also directly accountable to Scottish Government and COSLA. And the relationship between the two is that Public Health Scotland is there to advise the public health elements that boards effect at the front line. And it is very much an advisory role that we have. The Directors of Public Health do not in any way report or are accountable to PHS. in their work, which is a different model to what may happen in England. So the meeting that Ms Leach would have gone to with the DSPHs would have been something at the start that she went in order to support the Directors of Public Health, a very active group currently and during pandemic. But it was essentially their role as Directors of Public Health and the health boards to protect their population based on geographical grounds, whereas PHS had a national remit in supporting each of them.
The Scottish Directors of Public Health Care Home Working Group that was attended by Public Health Scotland, one of the main outputs of that group was the final joint framework for action COVID-19 care home settings, which was jointly drafted by Dr Ramsey of Public Health Scotland, and the inquiry understands that's dated in around April 2020. Does Public Health Scotland have any views on whether that sort of document was useful in dealing with different lines of accountability during the pandemic, and would something like that help in the future?
Oh, definitely. I mean, even in non-pandemic times, we work very much with the Directors of Public Health and their teams on the area of health protection, their health protection teams. But that was exactly a good manifestation of how we work together. What they agreed in that document with the input from PHS and also Directors of Public Health was no surprise, but also very helpful to get it down as a schematic that should be followed.
Just finally dealing with background, please. You explain in your statement that Public Health Scotland was aware of confusion between the role that Public Health Scotland played and the role of local HPTs at the front line, and I understand that's health protection teams. Why do you think that confusion arose, and did it have any impact upon the response?
So not infrequently, and it does still happen sometimes, frontline services will say, Public Health said that that's what we need to do, or this is a guidance from Public Health. And that generic public health term could mean, depending on the context, a local health protection team that is directly supporting services in the health boards, or it could be national, ourselves as a national agency that would be supporting or advising the health protection teams, but by reflection also advising the local services. So it would be important. A classic example might be that if a care home had an outbreak and they reflected that Public Health had advised them to cease visiting or undertake certain interventions, what they sometimes said was Public Health Scotland, and that wasn't the case because we did not have a direct relationship with care homes and services at Frontline. That was always through the health protection teams.
Thank you. Can I please move topic to infection prevention and control? And before we come on to the specifics of who was responsible for the guidance, can I first ask, in the view of Public Health Scotland, is nation-specific IPC guidance required for care home settings in Scotland?
So we take a Four Nations approach and always have, and all the more so during pandemic. And on the issue of infection prevention and control, it's important that any policy or guidance that comes out is reflective of how each of our systems work. Health is devolved, therefore our health systems are a little bit moderately diverse between the Four Nations. So an infection prevention and control remit, it's understandable that we have four teams that work on that, but they do work on a Four Nations approach. If anything goes awry in that relationship, certainly that can create a problem. But the evidence base that is gleaned in order to inform guidance and indeed policy should be the same and should use the same criteria to judge it. But there can be nuances and work that goes more or less in depth. So the Four Nations approach is paramount, but we appreciate and understand how that can be slightly different for the Four Nations.
So again, to slow down.
Sorry.
There is space then perhaps for nuanced advice in each nation. Are you aware of whether Public Health Scotland or RHI provided any training for care homes in respect of IPC during the pandemic?
So the training of staff in services is the responsibility of the employer. In local health boards, support for training can come either from the local infection prevention control teams, usually based in healthcare settings, hospitals, or from the health protection teams. And broadly speaking, although each health board can do it as best fits them, broadly speaking, infection prevention and control teams would support healthcare setting training, and health protection teams would support advice and guidance for in community-facing services such as care homes. However, there are over 1,100, I think, care homes in Scotland and 14 health protection teams, for example. So any training or advice and guidance that was brought from the health protection teams to care homes was very much focused on outbreak management rather than routine training. And I think that that's a need that needs addressed.
And would it be the health protection teams that would be best placed to deliver that training in your view?
Interesting question, something that really needs to be worked through. The health protection teams would use RHI's National Infection Prevention Control Manual for that training, so the resources there produced by RHI nationally, but who does the training is actually something for each of the health boards to determine.
Just a few more brief questions, please, on IPC measures. Following the 1st of April, there were 3 categories of guidance: health protection guidance that was developed and maintained by Public Health Scotland, health and social care IPC guidance developed and maintained by RHI, and then joint outbreak management IPC guidance. How was consistency ensured between Public Health Scotland and RHI guidance? So, for example, did the guidance interrelate? Did it have links? Can you help us, please?
I should also point out that there was a 4th element of guidance, and that was coming from Scottish Government.
Yes.
The links during pandemic on guidance matters were very easy, so to speak. We had been part of the same organisation up until the 1st of April. RHI and Health Protection Team, as it was lodged within NSS. And that relationship continued throughout a good part of the pandemic in a very close way. So when it came time for guidance to be written on an iterative and frequent basis, we were working very much in tandem. And in fact, in order to keep up with the changes in policy that then had to lead to changes in guidance, we took the tack in PHS that we would link directly to RHI's guidance. And where it was of additional benefit to provide a little bit more explanation, we did so in our guidance documents. But anything that we put into our guidance that was in relation to a specific point of guidance, if the policy changed, we had to do another version.
Great.
So we tried to keep it through links, that would be the way.
Now, you refer to 2 issues, if I can put it that way, in your statement, and you say 2.3.12, the lack of clarity contributed to some of the delay in issuing changes in relation to the guidance, since IPC policy positions came to PHS guidance teams sometimes at third hand. And then you also explain that PHS was responsible for supporting local health protection teams in their management of outbreaks, yet the guidance was owned and composed by RHI, and you call that an operational challenge. How were those challenges addressed in the pandemic, and is any further work ongoing?
Okay, so those are 2 separate issues. So briefly, the first one was really more about the pathway of communication from decisions being made or attempting to be made at a 4 nations basis by an IPC cell, infection prevention control cell, that RHI participated in with the other 3 IPCs of the 3 nations. And the way that information came ultimately to PHS, that we're trying to operationalise Scottish policy, was sometimes challenging. It could go down a route of directly, RHI was directly involved in IPC where decisions were being made and would reflect those back to us. But if there were, understandably, chief medical officers groups involved or Scottish Government policy people involved, the pathway could be more tricky, shall we say.
And can I just interject at that point? How was that dealt with during the pandemic practically?
It's a big point of learning, that one, I must say, and we've taken that on board to work with across the 4 nations much more closely on that, and to have a recognised structure pathway for that, including with infection prevention control colleagues. Sometimes changes that we would need to reflect in our guidance came to us very late in the day, sometimes even through press briefings by our political leaders, and we would immediately try to find what was meant by it, what the source was, what was the understanding behind it, in order to put it into our guidance, and that took time.
So better lines of communication may be one
Yes.
way. And just finally, in Module 3, Dr. Finn told the inquiry, I think it's important to realise that RHI's remit is defined because it's part of the NHS Assure, which is for healthcare-associated infection. That does leave a gap when it comes to community settings. He referred to the role of Health Protection Scotland in taking the principles that were developed for the healthcare setting and adapting and trying to use them in those wider settings. This is something that's being discussed at the moment to make sure that gap is addressed, and we're in active discussion with RHI and indeed with Scottish Government about how we address that going forwards. Was there a gap then as regards IPC guidance for the sector during the pandemic? And if so, how is that being addressed?
So during the pandemic, as I mentioned earlier, we were working very closely with RHI. I think probably the gap there was more along the lines that RHI's remit very much concentrates on healthcare settings. And in pandemic, suddenly we had to do a lot of infection prevention control interventions, guidance in relation to the wider community. Things like physical distancing was something that we were aware of it as a concept, a potential public health intervention, but actually finding the evidence base to back that up required time, and that wasn't in the outright remit of RHI. Hence, we did have a gap that Public Health Scotland very much wishes to address now.
Is work going on then to address that?
So there is work going on in terms of how these gaps that may relate to RHI's work and Public Health Scotland's work, how do we address them? Are there true gaps? And how can we fill them? But the other way to think of that, which is what we're also proactively taking forward, is working more closely at 4 nation spaces. So UKHSA on our guidance formulation, and you may be aware of the mpox outbreaks that arose in recent year. We were very much more embedded in with their guidance teams than during pandemic, and we hope to see more of that going forward.
Can I change topic then, please? And can I move to hospital discharge and testing, and moving to March specifically, please? And on the 12th of March 2020, Public Health Scotland produced guidance for the sector, and the inquiry heard evidence from Ms Freeman last week that this followed concerns raised on the 11th of March of reports that some care home providers were restricting new admissions and visitors. Was Public Health Scotland asked to include any information in the 12th of March guidance on accepting patients from hospital or wider hospital discharge issues?
So I can't quote you all the dates of each of our guidance documents, but I do know that there was also a PHS guidance document on that topic, the 13th, so things were happening quite quickly. In terms of discharges from hospitals, those were into care homes. That was something that government were looking at very closely at that stage.
But just specifically, do you recall if anything was asked to be included about that topic in the 12th of March?
Not as yet. That was being figured out, so to speak, and worked through with support of UKHSA and the Chief Medical Officer's team, etc.
And we'll come on to that in just a moment, but can I please have on screen INQ30189305, which is the 12th of March guidance, on page 11 under the heading Home Visits or Care at Home. Can I take it then that this was in part relevant to domiciliary care?
Yes.
And that guidance said people who have been in close contact with a confirmed case of COVID-19 are also being advised by the local health protection team to self-isolate. People who are self-isolating and have no symptoms do not pose a risk to others. And my question is, given the emerging knowledge of asymptomatic infection and transmission, so for example in February 2020 SAGE had been unable to rule it out, is there a possibility that that guidance may have provided false assurances?
It could have done, but it was very much a developing understanding that we had with this novel coronavirus.
Now, moving to the 13th of March then, please. You explain that the Scottish Government reminded services to continue to discharge patients into care homes, and the letter that was sent stated, in the early stages where the priority is maximising hospital capacity, steps should be taken to ensure that patients are screened clinically, to ensure that people at risk are not transferred inappropriately, but also that flows out from acute hospital are not hindered and, where appropriate, are expedited. And you explain that it has not been possible to identify advice provided directly by HPS, as it then was, to Scottish Government. However, the letter did include a link to the Health Protection Scotland guidance. In those circumstances, then, is it the view of Public Health Scotland that it should have been consulted on the contents of that letter?
So the letter that you're referring to is a letter from Scottish Government, not from us, yeah. Yes, as the Public Health Agency for Scotland, we take very seriously our advisory role to the health boards, but also to Scottish Government. That may have to do something with us starting as an organisation, since we worked closely with Scottish Government even before the institution of PHS. But when the pandemic came along, I think that our specific and structured advisory role to government was not as clear as we would have wished it to be. And we were often involved in such discussions through perhaps the Chief Medical Officer's team, but not directly in advising ministers.
Are you able to assist with what the view of Public Health Scotland was about discharges at that time? Did it think it was a sensible idea? Was it a requirement? What was the conversation in Public Health Scotland?
Yep. So in the March, it made sense that we could see this pandemic coming. We could see what was happening in other countries and the severe challenges that the health systems were undergoing with that. And so it was very logical that we had to make space for the more severely affected individuals who required hospital care. Therefore, creating that space by ensuring that only people who required to stay in hospital was what was happening was very much the right policy to undertake. There are always challenges with healthcare systems nowadays. One very clear one is that of delayed discharges, and that was an issue at the time in March, that it would make sense to find a better place for individuals who did not require to be in hospital for clinical purposes anymore, but should be supported in going either back home or to a replacement for their home. So we could see how that was a very important issue to consider. And as the knowledge and understanding of how the novel coronavirus was working, we also became very clear that one pathway, the one into care homes, had to be addressed carefully.
And if I can focus on the 13th of March, Public Health Scotland had a key role in testing and contact tracing. Did Public Health Scotland have an awareness of the number of tests available at the 13th of March?
Generally speaking, yes. Throughout that period of expansion of testing, we were kept very much briefed.
And did Public Health Scotland have access at this time to the numbers of people being discharged from hospitals to care homes?
That was more difficult.
Would that have been helpful information to be provided to Public Health Scotland? Is that data that is capable of collection? And if so, who should collect it in the future?
So that was a big challenge of the, I'm sure we'll come on to it, the report from Public Health Scotland undertaken by University of Edinburgh and Glasgow colleagues, where they had to look at the discharges from hospital to care homes. And if they didn't have an actual denominator of individuals to whom this related, then they couldn't do the work. A lot of time was spent in deciphering what that denominator was, what the numbers of individuals were that had a pathway from hospital to care homes, using multiple sources of data, because it wasn't there automatically.
Is it now available? So in the event of a future pandemic, is that readily available information?
I would have to check if it's readily available, but it's certainly the methodology that was used at the time has been progressed, most definitely.
And was Public Health Scotland ever specifically asked if there would have been enough tests available to test all patients on discharge from the 13th of March?
I think we knew that there wouldn't be, in terms of the priority for testing at that time was diagnostic. The system needed to make sure that people who had coronavirus, the novel coronavirus, and required hospital care were going into hospital care with that knowledge. So it was understandable that the primary priority for testing at the time was diagnostic.
And given that you've said that Public Health Scotland didn't have access to the numbers, is it right to say that it was never actually investigated if there would be enough? Was it an assumption that there wouldn't be enough?
We had numbers to the tests. We were kept briefed of the tests on a pretty much daily basis of how many tests were available at UK level in Scotland. But we didn't have ready access to the numbers of people coming out of care homes. But yes, that would have been useful. Coming out of hospital, sorry.
Thank you. Now, the letter sent by Scottish Government also said, based on the emerging picture around COVID-19, the CMO advice suggests that long-term care facilities should be subject to social distancing. Was Public Health Scotland asked to provide advice on the social distancing in care homes at that point?
If by advice you mean, as I would, that were we asked to seek the evidence base by which that was the thing to do? Not specifically.
Specifically, was it discussed with Health Protection Scotland as it then was?
Yes, and a lot of the information that we had would come from our colleagues down south.
To combat the risk of potentially asymptomatic patients being discharged into care homes, what is Public Health Scotland's view on whether all new admissions should have been isolated either before or upon entry to a care home from the 13th of March?
So the isolation of individuals transferring from hospitals where we knew there was COVID to care homes where, at that stage, unless people were symptomatic, we assumed that they didn't have COVID, was very important. We agreed with that policy, as isolation would be one of the hierarchies of control to institute if you're trying to remove a risk from a population. So that was a very sensible, albeit challenging, thing to do.
And do you think it should have come in from the 13th of March in retrospect or in hindsight?
What happened at that stage is that we were very much working on a basis of symptoms being evidence of infection, and the advice at that stage was anyone who had symptoms certainly would often not they wouldn't take that pathway into care homes, but anyone who had been in contact with someone who had symptoms or a diagnosis of COVID in hospital, i.e. a contact of exposure, was advised to be isolated as far as was possible at that stage.
Can I ask something about that? I'm sorry to interrupt. Given that, as Ms. Posey put to you earlier, the basis of someone being infectious, even though asymptomatic, had not yet been ruled out, and I appreciate that as scientists you act on evidence, but as I've heard expression a number of times, the absence of evidence isn't, I can't remember which way around it is, but anyway, the fact that you don't have any evidence doesn't mean that it's not going on. Surely the wisest course would be to say, look, we think it's only transmitted symptomatically, but just in case, we're going to recommend that everybody that's going from a high-risk environment like a hospital is put into isolation. Wouldn't that have been a sensible course?
It could be, but we also have to consider, and here's the discipline of public health where it comes in, we have to consider a number of factors when we provide that advice to people who are working at the front line. And if, for example, as we've heard, there were issues of PPE supply or training in the care homes, or even the buildings, in the main, I think we're adapt for that. But if those were issues, then issuing such a recommendation on the basis of what we call the precautionary principle might not have been the best at the time. I think there's little doubt that symptoms, and at the very start of somebody with symptoms, who might not even realise that they're coughing inadvertently, is a high-risk time, and therefore that was taken as the signal to put interventions into place. When it became clearer from others' experience and studies that were being done that solely relying on that might not be sufficient, then the advice changed.
But again, going back to the principle, surely it should have been, the advice should have been, care homes, unless you have the PPE, unless you have the isolation facilities, do not accept these people from a high-risk environment, because it might then spread through a very vulnerable community.
But if they were able to keep to the isolation principles, which they should have been able, and most of them did, in a care home where rooms for the main are single, then they would have been able to keep the individual isolated for the period of time accorded.
I think that was the point of my first question. But anyway, I'll leave it to you, Ms Paisley.
Thank you, my lady. Can I move to the 26th of March, please? And there was Scottish Government clinical guidance for nursing homes and residential care residents published on that day, and that incorporated Health Protection Scotland advice. And the guidance by that stage was individuals being discharged from hospital do not routinely need confirmation of a negative test. My question is, to what extent, in the view of Public Health Scotland, was that decision based on testing capacity?
I would assume as a policy decision that was the major factor.
And Public Health Scotland had also produced an updated version of its guidance on that day. What was the difference in reality between the guidance being produced by the Scottish Government and the guidance being produced by Public Health Scotland at this time?
So, generally speaking, and in relation to this, the Scottish Government guidance included more clinical notions that were very useful for care homes to use and abide by. Public Health Scotland does not have a clinical function per se. We are looking at the public health aspects of interventions and risk assessment, those that relate to a population, in this example, a population of a care home, and the risk factors that might make somebody more or less vulnerable to it. Whereas the Scottish Government guidance, with its clinical advisors, was also able to provide background information and advice on, for example, the condition of dementia that many of the individuals would have had who were in care homes, and other things such as therapeutics, if that were needed. But that wasn't the remit of Public Health Scotland guidance, so they added to that.
Now, the inquiry has heard evidence from both Ms Freeman and Ms Lamb that mandatory isolation for 7 days, either in a hospital or in a care home, was introduced on the 26th of March, and an annex was added to the Scottish Government guidance on that date. Can we have on screen the updated Public Health Scotland guidance at page 17, INQ 30189-302? And this deals with 14 days isolation for an exposed individual. However, it doesn't mention the 7 days mandatory isolation. Do you think there was a risk then that care homes could have been following one piece of guidance that didn't mention the mandatory isolation?
So I'm pretty confident that this guidance that you've put here, which I think you noted as the 26th March from PHS, would have also noted the 7-day issue. We have to be really clear here. And 7 days of isolation was what, at the start of pandemic, was advised for people who were diagnosed with COVID or thought to have COVID because of symptoms. And that reflected the period of their infectiousness as determined from the onset of their symptoms.
If it helps, this does deal with the 7 days isolation for someone who is symptomatic.
Yes.
But the Scottish Government at this point said that all residents should be isolated. And the isolation period could be in hospital or in isolation to ensure that they do not develop new symptoms. And so it's the 7-day isolation for everybody else that I've been unable to locate.
So remember that at this point in time, people who had COVID would not normally have been transferred to care homes. So those are the folk who would be isolated for 7 days. The individuals who would be on the pathway from hospital to care homes would have been those that had possibly been exposed to the virus in the hospital. And therefore, it was the 14-day period that anybody going into a care home should relate to, because we were waiting for the incubation period of 14 days to complete, so that and that they should be in isolation during that time in case the symptoms arose.
So that's for people who have been exposed. But I understand the Scottish Government's policy was that all residents should be isolated on admission for 7 days.
It could be that that was in reflection to the early point of pandemic, where the days were changing about how long somebody was infectious for. But I think what you're suggesting there, and I'm not quite sure if that's correct, I don't recall 7 days being a period of incubation period at any point. It could have been 10 at some stage. It could have been 14. So.
Could I just ask a general question on guidance, please? Do you think that the multiple sources of guidance in Scotland caused confusion? And going forwards, is there a way that that can be addressed?
I am confident it did cause confusion because we had feedback on that, and I know that the Scottish Government had that too. I think we need to work out what to do next time in a crisis. But let's remember that, generally speaking, it's not for the Scottish Government rarely puts out guidance in that is reactive and needs to work in terms of incidents. That is the role of PHS. The reason Scottish Government were undertaking that was because we were in that emergency footing type of scenario, whereby Scottish Government was leading the pandemic, even for the roles that PHS would normally have in an outbreak that wasn't a pandemic.
In respect of guidance provided to the sector then, what was the impact of the emergency footing on what Public Health Scotland was able to produce regarding guidance?
Our guidance essentially was operationalisation of policy that Scottish Government was developing. In an incident such as Mpox, for example, we would be determining we would be determining PHS policy, not government policy, obviously, but we would be leading on the response in an incident that was non-pandemic, as opposed to in the emergency footing, it was Scottish Government that clearly, legitimately, and for good reasons, was leading on the response to the pandemic. So our role then followed suit to make guidance to inform the local health protection teams on what needed done by operationalising that policy, how to make it happen.
In January 2025, Public Health Scotland produced health protection guidance methods for guidance development. Do you think that might go part of the way to address the potential for confusion in the various roles?
So the methodology piece of work that we've done on guidance follows on from 10, 15 years of the Scottish Health Protection Network doing similarly. And this January document revises that, makes it more robust. It's a guidance methodology that is very collaborative, takes in stakeholder views, and allows quite an extensive time period to happen. That methodology, it wasn't possible to apply it in pandemic because things were happening so quickly. There is provision with the methodology for a next pandemic, or indeed an incident that requires quick guidance, to take, so to speak, shortcuts, which may very well be along the lines of not being able to consult for as long as needed. But certainly that methodology is what we use now, and we are looking forward to seeing how we could apply it better for a next pandemic.
The inquiry heard evidence, returning to hospital discharge, please. The inquiry heard evidence from Ms Lamb that the use of step-down facilities or designated settings was considered by the Scottish Government and effectively discounted due to the potential for staffing issues or risks to people, including additional disruption. Was Public Health Scotland ever asked for advice about the use of step-down facilities?
I am not aware, but it might not have come to me at the time.
In the view of Public Health Scotland, is that something that should be considered for a future pandemic, particularly if it's factored into planning?
I think the rationale given for which that path wasn't undertaken in Scotland is pretty sound. I think what needs to happen differently is that there needs to be greater effort in training up care homes, should this happen again, in the notions of IPC in order to make isolation a true intervention for that setting. The problem this time is that they weren't trained up. They didn't have as much equipment or PPE needed as that would have been able to address that issue. It wasn't so much that a separate facility was required. The facilities could work if the training and the equipment were in place.
Do you think that it would be worth having step-down facilities as an option? So should it be included in planning for the future?
It should be included as an option, yes, because we don't know what the next pandemic will be, and it could be that the organism lends itself to those types of facilities being needed, definitely.
But in the view of Public Health Scotland, perhaps if there was greater training in place, that...
In infection control, yeah.
Can we please have on screen INQ 305842550, which is an email from Dr. Ramsey to a director of Public Health. And I believe this email makes reference to the Easter 6 study, and there's a long quote about that, so I won't read it all out. But it says PHE's prediction so far is that they expect, based on current trends, for 90% of all care homes to have been affected by outbreaks within the next 30 to 34 days, unless something is done to alter this predicted spread trajectory. The results were stark. Over 50% of the staff were already test positive, so infected, and an even higher percentage of the residents were infected. The conclusion is that by the time an outbreak is spotted using existing criteria, it's really too late to control it effectively. The conclusion of a public health meeting on Friday was that the emphasis on testing is misplaced and that the real emphasis must be on preventing infection getting into care homes at all. And I'm sorry, I chopped and changed through that quote there, but it's quite a long quote. These were clearly worrying matters for the sector. Was this escalated by Public Health Scotland to anyone in particular in the Scottish Government that you know of?
Yes, this would have been something that I don't know exactly to whom, but the government would have been aware of the work and the dialogue that we had with the directors of public health. I'm not sure if sometimes they would have been copied into such emails or at the meetings. So yes.
The inquiry understands on the 21st of April, Ms Freeman announced it would be mandatory for all hospital patients to have 2 negative tests on discharge, which I'll come to in a moment. But as a result of that email and the concerns, do you think that there should have been wider testing announced at that time beyond just the 2 negative tests on discharge, if there had been capacity?
So the thrust of the email that was just on screen there was outlining that the evidence that had been gleaned from the Easter 6 studies undertaken by UKHSA or through UKHSA was showing that by the time the care home itself had appreciated that they had ingress of the virus into the home, it was highly likely that many more folk than they expected were already infected. And therefore, doing testing would illustrate that, fine, but would it have impact? Because at the point when a care home is diagnosed, so to speak, with an outbreak, you must get the interventions into place. It has to switch to the interventions. So testing everybody at that stage would have been redundant, so to speak, once there was one case, we came to learn, by the time you have one case. The importance was getting the interventions into place. And the point that's being made in the email is that we need to shift our emphasis to prevention of it getting into care homes at all, because by the time it's in, it was so transmissible that it spread rapidly.
And in respect of the decision to require 2 negative tests on discharge, on the 20th of April, Public Health Scotland, the CMO Directorate and the CNO Directorate had advised for 14 days of isolation. And again, the position was no test required prior to admission. What were the reasons, or were they similar to what you've just been discussing, for advising that no test was required prior to discharge?
So if you are instituting isolation for anybody coming from hospital into a care home, anyone, then the test itself doesn't add much if you have somebody that has no symptoms, because you are undertaking the intervention that you would put into place whether their test was positive or negative. So the emphasis on testing, as is outlined in the email, was overly egged, shall I suggest? The important thing was that the interventions were effective and impactful once they were undertaken. And testing in this instance, the initiative did create problems, as you had an individual who was, for all intents and purposes, ready to go back to a home, or indeed their home, their care home, but was being prevented from doing so because a test had not come back as negative. And there are many reasons why a PCR test for COVID came back as positive, and yet it did not necessarily present a risk to the care home. One of them is, if you had the interventions in place at the care home, you could isolate the individual from others. But another one is also that we were learning all the time about these the PCR tests for this novel virus. And the PCR test is able to assess how much genetic material, or assess the presence of genetic material, but not necessarily whether the virus is viable.
I wonder if I can just, perhaps in summary then, it's that not that the tests weren't important, but the view of Public Health Scotland was that there were other measures which were perhaps more appropriate in care homes at this point than just testing itself.
Yes, and testing had its own potential disbenefits or harms.
Can I ask a question, please, on the PAC process that was put in place by the Scottish Government? Now, the inquiry has seen evidence submitted by Public Health Scotland that this process led to delays in guidance that was produced. And at paragraph 8.5.11, you say in one instance, Public Health Scotland advised Scottish Government of delays in 11 sets of guidance as Public Health Scotland waited for a response from the Scottish Government. 6 of the 11 guidance documents had been with Scottish Government for 9 days. And the inquiry has seen that a number of those specific pieces of guidance were relevant to the care sector, including both care homes and domiciliary care. Did Public Health Scotland agree with the need for the PAC process? And did it cause any particular delays as regards to the adult social care sector?
So PAC stands for Policy Alignment Check.
Yes.
Which meant exactly that there were concerns on the part of Scottish Government that Public Health Scotland's guidance sometimes, they thought, seemed to come out in misalignment with the government's policy. Maybe that was the case in some instances. I can't put my finger on any. But what it did do was, in its operationalisation, it may have allowed for a less black and white way of a policy being rolled out at the front line. So if I can give an example of the discharge testing, for example, yes, the policy was anyone going into a care home from that certain date from a hospital required 2 negative tests. But there were instances where that wasn't in the best interest of the individual and wasn't actually needed even to safeguard the care home. But with a policy that was black and white as we were getting reports from via our health protection teams from care homes, that was preventing people going back to their home when in fact they were fit enough to do so. So if we didn't put that nuance, that explanation into the operationalisation of the policy, then that would clog up the system, so to speak. So those types of reflections in our guidance sometimes were felt to be misaligned with the policy, when in fact there was good justification for that. A test always has to be consented.
And so just to clarify then, in the view of Public Health Scotland, was it necessary and did it lead to delay?
I would like to see in a future pandemic that we didn't require a PAC process.
Grateful. I have 2 final topics, and I just wonder if I could ask if you could keep your answers just a little bit shorter, if that's possible, please. On data, the inquiry understands Public Health Scotland acknowledges that there were gaps in respect of the data it held regarding care homes. Can you please give a brief overview of the difficulties in respect of data and whether any steps have been taken since to resolve them?
A key one I've already highlighted is that for individuals who are being discharged from hospital to care homes. And although the information could be gleaned from multiple data sources, that was something that we're working on just now. The we have a very good pathway of data for notifiable diseases and organisms, an electronic pathway from the Health Board's laboratories to Public Health Scotland, so that worked well. There was information, for example, on even care home outbreaks that we didn't have a system in place for, but if we had would have made things much easier, but also for outbreaks of all sorts of settings, not solely. And we're working that up with the systems that we have in place to make that a much more routine element of data.
And briefly then, dealing with visiting guidance, in your statement you say in retrospect a more nuanced and locally sensitive approach might have been implemented for care home settings in the summer of 2020, and a less restrictive visiting regime for some of this period would likely have led to some preventable illness and or deaths arising. Where does Public Health Scotland see the balance lying in respect of visiting restrictions in the event of a future pandemic?
So visiting restrictions for a care home were addressing the risk of the virus coming into the home when it wasn't already there. A key mitigation for that was vaccination once it was ready. So that came in December 2020. After that period, and a bedding-in period of rolling out of the vaccination and individuals reacting to that through their immune systems, that would have been the time to start to reduce on the restrictions, the quite heavy restrictions that were in place, both for visiting and other elements. And the impression is that the restrictions went on for too long. This was in the hands of Scottish Government, who were leading on the response. And we would have wished to have been able to influence that more and shorten the time period whereby visiting restrictions were in place and other interventions. So vaccination would be a key point, after which it would have been important to review more regularly and ease up on the restrictions.
And just one final point before I ask for your final reflections. I understand Public Health Scotland wished to clarify whether it had any role in the regulatory inspections during the course of the pandemic. And I just wonder if you could assist with that.
Yes, we have no role in that. An advisory role to Care Inspectorate, as we did when requested.
Now, beyond anything we've already covered in your evidence, are there any further recommendations that you would urge the inquiry to consider, please?
So I think we've touched on the role of Public Health Scotland in advising government. We would like to see that more structured as we move forward, particularly for a next pandemic. We haven't touched very much on the human rights-based approach that we've already done much work with Scottish Government in the sphere of care homes, but we would like to see that progress, and it will do through a code of practice on Anne's Law, but bearing in mind that there still needs to be safeguarding from what our health protections do in supporting care homes that have outbreaks. The testing we've also touched on, and it would be really very useful to have some sort of evaluation of testing during a pandemic at population level. The very expansive, it's not specifically related to care homes, but that was part of it. And I guess finally, strengthening IPC, and we've touched on the collaboration both at Four Nations basis and with other organisations, including our High.
Thank you very much, my lady. Those are my questions.
Thank you very much, Ms Paisley. Ms Mitchell, who sits up there.
I appear as instructed by Amar Anwar on behalf of the Scottish COVID bereaved. Donald McCaskill, the CEO of Care Scotland, that's the membership body for organisations that provide care in care homes, home care and housing support across Scotland, has given evidence to this inquiry. And part of that evidence related to the relationship between Public Health Scotland, or as it was then HPS, and itself. And he said that they were disappointed with the process of the development of the guidance of the 13th of March. He said, "We found that there was a minimum level of engagement with Public Health Scotland in the time of the guidance, as was seen both here in the necessity to repeat that guidance, and that meant to change the guidance from the early days of the 13th of March to the later guidance. Mainly as a result of our demonstrations later in the month, we found, both here but also through the main, professional respect from Public Health Scotland and its understanding of the social care sector and its unique situation, particularly in relation to infection prevention and control in care homes, to be wholly regrettable. Were you aware of the views of Care Scotland at that time, i.e. March 2020?
I was aware of it. I wasn't involved directly in that aspect.
Were there any steps taken by Public Health Scotland to resolve the issue?
So there were a number of groups that Scottish Care as well as PHS partook of in the sphere of care home work throughout the pandemic. So that would be a key way of undertaking that. The other way was through the advice that was being given to government and the feedback that Scottish Care were offering government, and trying to play into that and provide our advisory role a little bit better. But that, as I've mentioned before, that was already quite challenging.
Well, I'd like to ask about the feedback that Care Scotland gave. Care Scotland indicated that they had limited engagement in respect of the guidance on the 13th of March. And Mr McCaskill was asked whether or not he was given time to consult, and he was asked, is it correct? I think you were only consulted, is it on the 12th of March about the draft guidance? And he said yes. And given the quite tight time frame, a matter of hours to make comments. And it's not just in terms of admission. We made comments about the reality of how difficult it was to transfer a system of essentially infection prevention and control methodology developed for an acute sector such as hospital into an environment such as a care home, particularly as a residential, but including a nursing home, which was first and foremost somebody's home. Were you aware of the fact that Care Home Scotland, that Care Scotland considered it had been given insufficient time to have input into this process of the guidance of the 13th of March?
Yes, and time and pace were a big limitation of everyone in the pandemic effort. I can't remember what the date of the previous guidance to the 12th of March was, but we did produce the 12th of March, and then we produced the 13th of March. So you can imagine that the time to consult with various partners would have been very challenging and limited. That's not to say that we shouldn't find a better way of doing that, obviously, but there were time imperatives based on something that actually we were trying to operationalise what was coming from government. So even getting that took time.
Indeed, I wholly understand the imperative of time. It just seems a very short period of time for that whole sector to respond in that way, given we know what the limitations of the guidance were available for the care sector. Do you think it was too short?
Yes, all of our time was too short to undertake the challenges that we were dealing with, definitely.
Moving on then, in relation to testing, what Mr McCaskill said was this. Against that backdrop, we then had the new coronavirus being introduced, and we were very clear as an organisation, listening to our clinical colleagues out in the field, that they needed additional reassurance, and simply saying, we leave this to the professionalism of clinical assessment. I'm sorry, it didn't wash at the time. I communicated that to the Cabinet Secretary, and I indicated what we wanted and needed was testing to evidence a negative test, which with nothing else could mean, and we appreciate this testing was for the moment, and I think you've highlighted that caveat in your evidence already, and we appreciate that testing was for the moment, but it would mean a reduction in the potential period of isolation for an individual in a care home. Were you aware of the views of Care Scotland about the need for testing before discharge?
Yes, I can't say precisely when, but yes.
Do you think that would have been before the policy was put in place to allow without discharge?
I can't say.
Given the views of Care Scotland's undeniable expertise in this area, why were those views and their concerns not followed?
So You've noted the understanding of Care Scotland in relation to the tests to be applied to individuals coming from hospital to care homes, and the seeming understanding that if 2 negative tests derived from an individual who is still in hospital but making their way to a care home meant that their isolation in the care home would reduce in days. That's not the case. I think that was part of the problem of the over-reliance on testing, that there were, it was very difficult and challenging. We were all learning, but it provided false assurance in many instances for someone, an individual going from an area of risk, hospitals, to an area of, let's assume, no risk, a care home that didn't have the virus as yet. If they were negative upon departure from the hospital, but had not been in so-called isolation at that point, they carried that risk for another 14 days into the care home. Therefore, the negative tests would have been not of much help at all.
I see what you say in relation to false confidence, and I think Milady picked up on this in her question to you. It was at a time when the very most vulnerable people were at greatest risk, and there were no other procedural safeguards in place. So surely, even though limited as it was better than nothing.
Well, there were other possibilities. You could keep the individual in hospital, but at that point you had to balance the risk of staying in hospital for someone who otherwise didn't require to from the benefits of not. You could, as we advised, have them in isolation in the care home. And if a care home struggled with that, they had the health protection team to advise them on it 24/7. And we worked 7 days a week at that stage. But there was also an on-call service that the care home could call upon if they couldn't figure it out, if they had difficulties with equipment. I'm talking about the isolation once the person had transferred. And we've heard also about facilities could have been used as step downs, but that also was considered. So there were choices, and choices have to be made on the basis of the balance of harms and risks, benefits. Sorry.
There came a stage when when a report was brought out in relation to where COVID may have come from when entering care homes, and it included staff movement, but it also included the possibility of a relationship between positivity and outbreak in care homes. And then I think, as you'll understand, or perhaps you confirm you do know, that at a later stage, the report was slightly changed as a result of the Office for National Statistics getting in contact.
Yes.
Are you aware of that?
Yes, yes.
And are you aware of the reasons why it was changed?
Yes, I've seen the letter from Mr. Humphreys, who made reflections on the October version report, which PHS then revised, according to his advice, into the April version. And he did not object to the methodology used or the results or conclusions, but strongly suggested that they could have been outlined more clearly. And that is the extent of, not the extent, but the nature of the changes undertaken for the April report, in addition to including some further information that had come to light.
Indeed, that further information, including some wrong instances that people were included in care home discharge when they weren't.
So I think there was an instance of 6 discharges that were recategorised as not being from hospital to care home, and that was a reflection of the challenges around the data. And in the interim, after the publication in October, the team had noted that there were 6 discharges relating to 3 people who had not actually gone from hospital to care home, and therefore in the April report they were excluded.
But there was also a different emphasis placed, was it not, on the understanding of a causal relationship between positivity and outbreak in care homes? So
what was being assessed was the discharge from hospital, and some further information was done on whether a person was tested negative, tested positive or untested in further analysis. But that didn't change the conclusions and did not increase the causality of the study, because the study was not of using the method that could outline cause and effect. It could only give an observation as to what may be acting here in terms of risk factors. Indeed. And the dominant risk factor was the size of the care home.
Indeed, and part of the difficulty with the whole report was that the data, you've referred to data earlier, was very limited in relation to the period of time when the first discharge was made. Is that correct?
Limited in what way?
The data was limited in respect of there being little information in relation to testing because there was so little testing being done.
The team that undertook the report took all tests and all people discharged as they could identify. The challenges were around how they gleaned that. So yes, there are always potential for certain individuals or discharges to have been missed.
Indeed. Moving on then. You touched upon visiting restrictions, and I'd like to take you back to that. One of the most distressing post-pandemic issues for people that lost loved ones, as I'm sure you may appreciate, was that there was no consistent visiting guidance given by any public body to any care home. And as a result, people now consider whether or not they should have done things differently, or they blame themselves, they should have tried harder. And of course, that's clearly not their fault, and that should be made clear. What, in retrospect, do you think Public Health Scotland should have provided some guidance, even at a high level, to allow people to know when it was appropriate to ask for a visit and when not?
We did do that in our guidance. We outlined that for a large part of the pandemic, that when there were the severest of visiting restrictions in place, that there should be, based on individual risk assessment, the possibility to attend to visit a loved one in a care home in that end-of-life phase, or to relieve distress. So we did give those high-level pointers. I think the point that you're understandably making is that could be left to interpretation, but I'm afraid that's the way that risk assessment in the public health sphere works. There has to be a review at that individual level, and it doesn't have to take long at all, of what the harms and the risks, the harms and the benefits are of undertaking a certain action. And if a care home manager was thinking, gosh, this guidance, I'm not sure what they mean by distress, they could have picked up the phone to the health protection team. And the onus should not be on the relatives and friends that found themselves in the midst of that. That is true. That will have been very difficult for them. But there were resources in place to try to support that process and allow for exceptions, 2 of which were outlined in our guidance.
If there were such guidance and were such resources available, but the experience of the Scottish COVID bereaved was that they were at a loss, going forward, would it be better then if such guidance was made perhaps more strongly or more obvious to those that would need it?
So the initiative around that's led to Anne's Law has tried to address that and has, to all intents and purposes, addressed that. But many of the principles that are outlined now in statute through Anne's Law over the course of the pandemic came into being even through our guidance. So at one stage, and I can't recall when, perhaps even a year into the pandemic, we tiered the type of visiting that might take place in a care home, from routine when there was no outbreak to named persons, where every individual could lodge with the care home management the names of 3 people that, if there were an outbreak and residents were limited to 1 visitor per day, it could be any of those 3. But even there, if none of those 3 were available, it was perfectly fine for an exception, a 4th person to come on board. And that's where that risk assessment tries to help the process. And the 3rd tier was if for some reason it was completely clear that there should be no visits into the care home, then only in those instances would a named person, 1 per resident, not be allowed in, but only for end-of-life or distress situations.
Thank you. Milady, those are my questions.
Thank you very much, Ms Mitchell. Thank you very much indeed. That completes the questions that we have for you. Thank you to you, obviously, Dr Rossi, for your help, and also to your colleagues who helped contribute to the witness statement you provided. And don't worry, if there's stuff included in the witness statement, I promise you that's always considered, as well as the oral evidence you've given.
Thanks.
So thank you very much indeed.
Cheers.
I shall return. I'm sorry, we've got a lot to get through today, and I have to rise early, so 10 to 2.
All rise.